Good day, everyone. How y'all doing? I had a heck of a morning. I really am sincerely, like I said, apologize for this if this caused you any trouble. I'll try to get through the information quickly yet thoroughly so that this doesn't take up too much of your time. And then a lot of the concepts that we bring up today will be embedded throughout the rest of the semester, and I'll come back to them. So we will get plenty of chances to layer on, but I do want to make sure that we cover some of these key points. As a reminder, these slides are available. I wrote down detailed notes to go with the slides, so you have access to both of those. So let's jump right in. So what we're going to do today is do an overview of diagnosis and evaluation. And when we say diagnosis, the definition of diagnosis, the old Greek definition, is to distinguish. Well, what are we trying to distinguish? And that's really what we're doing when we're making a diagnosis, is distinguishing some sort of difference. And it's a difference from what? Well, one thing that we're often interested in is this a difference from normal? And normal I have in quotes because normal is a wide range. But is this enough of a deviance from what we would expect? And we'll talk more about this in a slide or two. Is this enough of a deviance from what we would expect and really having an impact on this client's life that it's clinical, that it's clinically significant? So that's that's what we typically think of is, do you have a language impairment? Do you have aphasia? Do you have a fluency disorder? Do you have a voice disorder? Something else we want to do when we distinguish is distinguish the pathology from other pathologies. And this is what we call differential diagnosis. So, is that pathology really aphasia or is it really apraxia? Or do we have comorbid aphasia with apraxia? Young children, a common referral that we get is a 2-year-old who's not talking much, really hard to understand. Well, is that a phonological disorder or is that a language delay? And it can be really hard to make that differential diagnosis, so we really need to dig deeper in with our evaluation to try to make that differentiation. Or we might say that they are comorbid. They occur together. You have both a language impairment and a phonological disorder. This can also occur when we work interdisciplinarily. Is that the right word? I don't know. When we work on interdisciplinary teams. So let's say we have a young child suspected of having autism. Now we might need to make a differential diagnosis between an autism spectrum disorder or a language impairment, because a language impairment can often have some similar symptomatology as an autism spectrum disorder. And like I said too, we may also find through our evaluation that we have comorbid autism with significant language or communication impairment. So that's what we're trying to do when we're doing our diagnosis. And when we do the diagnosis, this is going to be one of the big themes throughout the semester. You're going to hear me talk about this over and over again. What are we doing when we do our assessment, our comprehensive evaluation and making a diagnosis? The first thing we want to do is we want to identify if there is a problem. We want to identify a problem. And just kind of spoiler alert for the next few classes, typically our better instruments for identifying problems are our standardized norm reference assessments. Now we don't want to rely on them exclusively or over rely on them, but this is what they were designed to do. Those tests were designed to show your relative standing compared to some sort of normative sample. So if we want to identify if you are similar to this normative sample or different from this normative sample, these tests do a reasonably good job in most situations. We'll talk about exceptions throughout the case as well. But we don't stop there. If we've identified the disorder, that's just part of the puzzle. The second part is describing the nature of the problem. What are some relative strengths? What are some relative weaknesses? What are aspects of activities and participation that are particularly affected? What are some supports that are available, some contextual factors, some supports that are available to help out the client? What are some factors that may be having the client have even more difficulty communicating that are outside of his or her immediate control? So that's really getting to the heart of the disorder, describing the nature of the disorder. And this is really important for two reasons. One reason that this is important is because this is what we want to do. We know that our impairments, our pathologies are heterogeneous. There's a lot of variability. So we want to be able to accurately describe so we can capture the nature of this one individual's pathology. What I would argue is the more important role of this is going to lead very naturally into treatment planning. So let's say that you have aphasia. Okay, you have aphasia. So what's the next step? Well, we don't have one aphasia treatment. We have many different types of treatments and combinations of treatments and dosages of treatments that we can prescribe. And in order to tailor that treatment to the individual, to individualize the treatment, which is what we're really good at as speech-language pathologists, we need to really have an accurate representation of what's involved with this pathology. So that's where we need to determine the nature of the problem. So again, when we identify the problem, what we want to do is we want to document that you're performing significantly below your peers. So that's what I alluded to in the previous slide. Norm reference tests do a pretty good job at this, and our other assessments can do this, showing that you truly have some difficulty communicating. You truly have a voice disorder, a swallowing disorder, whatever pathology we're talking about. This is true. Your true performance is below that of what we would expect. And it's also having a significant impact on your life. And it may seem silly to put these together, but let's say that you have a little lisp. That may be significantly different than your peers, but you don't care. It has no impact on your life. In fact, it's a unique characteristic that is important for you. So that would not be a pathology. Most of our pathologies are going to have a significant impact on your life. If you have severe aphasia and you have very limited ability to vocalize and verbalize, you're going to have significant difficulty communicating. If you're a child with autism spectrum disorder and you have, your language skills, will say, are 3 standard deviations below the mean, so, age equivalents are bad to use, but just as a rough ballpark, if you're 6 years of age and your language functioning is at 2 years of age, you're obviously going to have difficulty communicating, and it's going to have an impact on your life. But it's something we want to consider and keep in mind. And the last part, this is what we're going to talk about in the last part of class, is we want to ensure that these differences are true disorders and not just differences due to cultural background, due to your native language spoken, due to a dialect spoken. Oftentimes these cultural differences can mask themselves as communication disorders. But we're in the pathology game. We're not in the difference game. We can do work on differences. We can do accent reduction. We can reduce dialects, but that's not our primary goal. In fact, you don't even have to be a speech-language pathologist to do that. I recently learned you can go through some sort of dialect training program, and you can work on that because it's a voluntary service. It's not a true communication disorder. It's not a pathology. So some of our common speech diagnoses, these are what you've been learning all about. Aphasia, language impairments, phonological impairments, apraxia of speech, swallowing disorders, fluency disorders. So we have a wide range of diagnoses that we make. And we want to think about, is it really important to declare that there is or is not a problem? And those of you who read through the chapter saw where, they talk about this kind of pro and con of, you can be too premature with reaching a diagnosis, yet at the same time, if you don't make that diagnosis soon enough, that has problems as well. So I want to talk about that just for a minute. Why is it important to declare that there is or is not a problem? Well, one is more practical, and probably the first one that comes to your mind. If you want services, oftentimes we have to document that there's a disorder. If you want insurance to pay for services, we have to document that there is a language disorder, a phonological disorder, aphasia, whatever, apraxia, dysarthria. So that's kind of straightforward. The second one I think is less straightforward, and you may come into this the more that you get into diagnostics. You're going to be in situations where you're not really sure. You're on the fence. A lot of our I have a quote later on showing this that's not very inspirational, but a lot of our diagnoses aren't clear cut. So, if you're making a high stakes decision of whether or not you have a disorder, we want to get it right. So it might be tempting not to declare that there is a problem. You also will experience where, you're going to have some patients who are going to take the news really hard. If you think that a child has autism and the parent has no idea or is strongly against that diagnosis, that's going to be an awkward situation. And in fact, this is something I struggled with a lot as a young clinician. And never have been one who was very good for confrontation. And what I learned was the more upfront and the more honest you are, 9 times out of 10, the better off you're going to be, and actually the better response you're going to get from the parent. Typically, we're going to talk about this in a minute too, when people come to see us for an evaluation, it's because they're aware that something is going on. So, I think if we declare that there is a pathology, if we feel confident there is a pathology, then it's being honest with our clients, it's being honest with the families. It allows us to have a clear course and a clear set objective for what we're going to do in our treatment, our treatment protocol. It also really will help us with prognosis. So, for example, if we have a 2-year-old child who's not talking, and we're not sure if it's a language delay or autism, we know that those two pathologies have very, very different prognoses. A language delay has a very positive prognosis. A child with a language delay is much more likely to catch up and be within the normal range, whereas a child with autism is much less likely to catch up. So we really want to think about these carefully. We want to get them right. We want to be honest with them. When we want to determine the nature of the problem, we want to think about, well, how are we going to get this rich description? What we tend to do is we tend to do our more naturalistic, descriptive, informal assessments. Observe someone communicating in a functional situation. Interview other stakeholders, so teachers, parents, siblings, spouses, and really try to find where we see some strengths, where do we see some weaknesses, where do the breakdowns occur. If we really want to hone in on a certain area, so let's say, for example, discourse skills, we may really want to do some deep, rich assessment, observing and testing out different discourse scenarios. So let's say we have someone with a fluency disorder. We may want to see, how do we do in casual conversation versus more technical conversation versus more stressful conversation. How do we do with a variety of conversational partners? So really trying this, again, get that rich description of where are the strengths and where are the weaknesses. We tend to not be able to get this information as much from our standardized norm reference reports. It's very tempting to do that, and we're going to talk about that quite a bit in the next few weeks. But really, what's thought to be the best way of getting this information is these more informal descriptive assessments. And when we use these descriptive data, like I alluded to before, what we're really trying to do is we're trying to characterize the disorder, and this will lead naturally to planning for treatment. So, we can do incomplete diagnoses. So one thing we can do is we can describe and describe and describe and describe, but never really give that diagnosis. And this may be tempting to do if we're unsure, if we're kind of on the fence. And the problem with this is we're kind of proceeding blindly. And I apologize for the blind pun here. Anyone who watched American Idol, this is probably like 5 or 10 years ago, American Idol, he's trying to high-five the singer who has a vision impairment. Again, like all those things I was talking about before, if we just simply describe without diagnosing, we don't really have a good, strong picture of what the disorder is. We don't have common ground that we can communicate with other practitioners and communicate with the family. It leads the family on. It can lead the family on. It can leave the family hanging. That's also kind of what this picture showing is he's leaving Seacrest hanging. That's the problem. The other thing we can do is we can make a diagnosis and not describe. And honestly, this is what happens more often is, we make this premature diagnosis. We just jump right in. And the problem with this is, what if we got it wrong? If we don't have a rich description, we can't really fully individualize our treatments based on that. So, both of these are problems, and both of these things are things that we're going to want to watch out for. Also, when we're doing our diagnostics, we want to think about what's the cause, what's the etiology of the disorder. And when we typically think of etiologies, we think of what happened before the onset of the pathology. So if you have a broken arm, the etiology of your broken arm was falling off your bike. That's pretty clear cut. If you have a cavity, one of the precipitating factors leading up to the cavity could either be genetics or poor dental hygiene. With our pathologies, it's a little more difficult. With some of them, it's fairly easy. If you have someone who had a stroke and then had severe communication impairment after that, such as aphasia, it's pretty clear that stroke was a precipitating factor for aphasia. Same with dysphagia, swallowing disorder. You have a stroke and you can't swallow anymore. That's a pretty clear precipitating factor. Now, what about something like a fluency disorder? Well, we know there's a genetic component, because people who have fluency disorders tend to have parents or grandparents or siblings or cousins who had fluency disorders. But we can't really track it to a specific gene, and it's not like other genetic disorders where we can find carriers and things like that. So we can't really fully say that that's a precipitating factor. There may be some environmental causes, both physical environment, so environmental toxins, as well as emotional, social, environmental issues. So with a lot of our pathologies, it's really difficult to identify what are those precipitating factors. We're going to get a lot of questions about, why do we have these, especially for our own unknown disorders. So why does my child have autism? Why does my child have a language impairment? So we want to understand what are the major theories in our pathologies and what some of these precipitating factors would be. And we want to have an honest and frank conversation with our parents. Again, that often will relieve parents and really leave them more informed. Something else we want to consider is perpetuating factors. So these are things that happen after the onset of the disorder that help to reinforce the disorder. So for example, if you have a language impairment, and when you communicate, that message isn't received by people, it doesn't have an impact on people, well, you may be less likely to try to communicate then, because you're not having an effect on people. Maybe even you're getting some bad feedback when you try to interact. So you're not going to communicate as much, which means that your communication isn't going to develop as well as someone who's communicating a lot. If you have a fluency disorder and you get really anxious when you're talking with someone and you start to have disfluencies, that could increase the amount of disfluencies that you have, and again, perpetuate that disorder. So these are just things that we want to think about as we're trying to identify what are some of the different sources of the communication deficits that we're observing in our clients. And the reason why we want to know the etiology, again, our clients are going to be interested in this. They're going to want to know, so we really need to have a thorough understanding of our disorders, our pathologies, and what is causing them, and the major theories, the valid scientific theories. We also need to know the etiology because it's going to inform about prognosis, which I alluded to earlier. If we have a good understanding of what the disorder is and the etiology, any perpetuating factors, that's going to give us a better understanding of what the course of treatment is going to look like, maybe how we need to do dosage of treatment, which treatments to choose, and what's the ultimate prognosis that your client has. What's the likelihood that they're going to either remediate the disorder or maintain the disorder. So what I want to talk about next is this kind of art versus science of diagnosis. And when we talk about art versus science, when we talk about science, what we tend to be talking about, or the scientific approach, we talk about more formal tests. These are standardized norm reference tests. They're really nice because they provide objective data, or what I should do, objective data. They're really nice because it quantifies behavior. I don't have to do air quotes for that one. It does quantify behavior. That quantification isn't always accurate. But it's really nice to have that data. Again, if we're trying to make this decision of do you or don't you have the pathology, it's nice to have objective data so we're not just relying on these biases. Informal testing, these are going to be more of our gut instincts, our clinical impressions. We observe and do we see, that the disorder exhibits itself more in certain times? Do we see that maybe, we didn't have accurate information in the formal testing, and we see a very much different picture when we do the informal testing? So, these are two, again, in the next few weeks we're going to talk more about the formal testing. Then the following weeks we'll talk more about the informal testing. Again, it's going to be a theme throughout the semester. So this quote was in the reading: "The scientific approach demands rigorous adherence to standardized procedures and has its favorable characteristics: objectivity, quantifiability, and structure." Yeah, I love formal tests. I love the scientific approach. It gets me excited to score standardized tests and look up the percentiles and the standard scores. I like having that objective, quantifiable data. It makes me feel good. I can sleep well at night when it confirms some of my hypotheses about an individual client. So some of the advantages are that we are being more objective, so our biases aren't coming in. Another thing is it's effective at overcoming our heuristics. So I want to talk a little bit about this word heuristics. A heuristic is a kind of a mental shortcut that we make. And it's used oftentimes in diagnostics. We develop these heuristics or these shortcuts that make our assessments easier, and it's not necessarily conscious. A lot of times it's subconscious. So for example, I remember when I was working at the hospital, Toy Story was really big at the time. We had a child come in who wasn't communicating, and then I'd hear him going down the hall, "To infinity and beyond, to infinity and beyond." I used to joke that I thought, Toy Story should be part of the DSM-4 criteria for autism because, the kids tend to have these very restricted interests, stereotype behaviors, not good language, but can do this more gestalt language use. But that was a heuristic, that was a shortcut of saying, all right, I see this, I've seen a lot of other kids with the same behavior and they typically have autism, so this child is likely to have autism. And I go into this with a bias. Now, a way of overcoming this bias is to be much more objective with how we approach it. The problem with that is that if we get too objective, if we rely too much on quantifying behavior, we really lose perspective of what we're measuring. We're measuring communication. We're measuring interacting and engaging with other people. That's really hard to quantify. And a lot of times the things that we quantify, like how many words do you know and what morphemes do you know, at the end of the day don't really tell us a lot about your communicative ability. And again, these tests are imperfect. And in 2 weeks we're going to see some data showing how surprisingly imperfect these tests are. So we can often be overconfident in the quantifiable information that we get that can often be inaccurate. So again, I love the scientific approach. It's just we have to be careful. We have to be careful. And what we need to do is we need to even it out. And before we even it out, we'll go to the other end of the spectrum. So then we have the artist. The artist is perfectly willing to disregard formal test results or standard testing procedures in favor of what appears to be obvious based on clinical experience and expertise. And this is true. This is a big deal. The diagnostics is an art. If we look at evidence-based practice, which we'll talk about more in the semester, just as equal with the empirical evidence is clinical expertise and family values. But all of those go together to form our evidence-based practice. So we know that when we're looking at any type of human behavior, such as communication, we can't just look at it objectively. We have to get some subjective impressions. And those of you who've worked with clients understand this. The test may show you one thing, and oftentimes it's right, but it may not really capture the essence of the disorder. Or, we may have had a really bad testing day and we see that if we make these modifications, this child can have a lot of communicative success. Or maybe this child fooled us and they did okay on the testing, but really they can't communicate worth a darn. I just recently had a client just like this that scored just fine on our formal language testing because he had a pretty good vocabulary for his age and had decent receptive language and some expressive language, but he wasn't communicating, right? So he was talking, he was producing words, he was a sweet boy, he was smiling, but he couldn't do a simple gesture for a request or a gesture for a comment. And those of you who remember language development class, those are very early developing skills. So our standardized testing didn't pick up on this. So in fact, with this particular case, I disregarded some of that standardized testing because the more informal testing, which wasn't as sensitive to the more pragmatic communicative functions, really picked up on the essence of this child's disorder. And that hypothesis was conferred with other data bringing in. So it wasn't just my gut telling me he has a big disorder because he's not asking me for things. He could just be shy, but we're getting data from multiple places. So what we want to try to be, and like I said, if the other one is good at overcoming heuristics, this we really get these rich descriptions, but we have to be careful that these don't lead to heuristics, that these don't lead to having some sort of clinical biases. So what we want to try to do is find an in-between, and we'll talk about that in a little bit. Another point I want to make just briefly is this idea of diagnosis versus eligibility. So when we make a diagnosis, that's really more of a clinical judgment based on the empirical research literature. So for example, with the general consensus is that 7% of the population has a language impairment, developmental specific language impairment, and a good criteria for that is 1.25 standard deviations below the mean. Now, if we look at Wisconsin data, about 3% of the kids receive services for a language impairment, and the reason why is because you have to score 1.75 standard deviations below the mean. Now, that doesn't mean if you live in Wisconsin, if you have 1.5, for example, or 1.3 standard deviation below the mean, and you're not getting services, that doesn't mean that you don't have a language impairment. You still have that impairment. You still have these difficulties in your life. It's just that you're not eligible for services. Okay, so most of the time we can blur these thoughts, but I think it's really important for us to think of this, especially when we get into situations of, what type of clinical practice are you in? If you're in a clinical practice that has strong eligibility requirements, a medical facility, a school, that's pretty much going to guide your life. If you're in a private practice clinic, if you have more flexibility, then you're going to have to rely more on the literature for making your diagnoses and saying whether or not you're eligible for services. I think that services would be of benefit. Next thing I want to go through is, when we think of social sciences, we also know that clinicians tend to play a role. We're human beings. So what are some different traits that we observe, and how do these influence the clinical decision-making process? So the first one I want to discuss is what I've affectionately named the old curmudgeon. So this is, a lot of times we get really set in our ways and we develop something that we think works really well, and we stick with it because we think it works and because we're comfortable with it. So those of you I remember last time several of you talked about the PLS. It's such a pain in the butt to give. And if you've been given the self preschool for years and you know it by the back of your heart, it doesn't really make sense. And you try to give this PLS and it's really weird. You may not be likely to use it because the other one's much more familiar to you. And I've heard many, I remember I was at a meeting, not here at UWM, somewhere else, and I said, well, how do you know that test is valid? And the clinician said, well, I know because I've been giving it for the past 20 years. And I laughed, and I probably shouldn't have laughed because this was a fairly important person. But that was the logic. And again, you can see it, if it's, her point was, I know I've been given this for a lot of time, in my experience, this really captures the disorder. But in my mind, that's really flawed logic. It's, this is valid because I give it. There's no logic there. So, we want to be open to new developments, new assessments, new research supporting different practices, and not just get set in our ways. Now, the flip side of the curmudgeon is the eager beaver. So you can call this recent article syndrome, recent test syndrome, where, if all of a sudden this new test comes out, every kid gets this test. Or I read this article about whatever the new fad is, and I shouldn't say that too lightly, but let's say apraxia of speech. I mean, that's a pretty common one. I remember when I started my master's, that was just kind of coming out as the hot thing. And I remember even myself, when I came out, I thought, I diagnosed many kids as having apraxia of speech, and I had no reason to do that. It's just that, they had a really severe phonological disorder. But, it was really cool and trendy, and, you were cool if you did apraxia. And, it's just because it was the latest, hottest fad. Another type of diagnostician that we see, people who get really into diagnostics tend to start to learn a lot of different tests, and they can administer them really well, and they understand what's in the tests really well. So this could be, where we feel really comfortable giving 4 or 5 tests, and we can start developing profiles, based on strengths and weaknesses across these tests. And that might seem like it's really good for getting a nice, rich description. But we're going to talk about the flaws of that in a little bit. What these tests, and especially the norm reference tests, were designed to do really well is identify the presence of a disorder. Now, once we've identified that presence of the disorder, what do we want to do next? We want to describe the nature of the disorder. Okay, so really we shouldn't spend all this time doing tons and tons of standardized tests. Once we've established there is a disorder, we need to move on and really do a rich description. And the best way of approaching that is not by giving 6 different standardized tests. I'm gonna back that up with data later on supporting why I feel that is the case. But this is a very common phenomenon that we observe in speech pathologists. I observed it all the time. I did it. I used to do it all the time. So just something to be aware of. And I like this quote as I was reading the chapter this morning. Because many of our this is like the 3rd sentence in the chapter. Because many of our diagnostic tools are imprecise, being largely in the experimental stages, and because by nature communication disorders are complex and perplexing, I kind of messed that up. Many of our diagnostic undertakings are incomplete and ambiguous. It's a nice motivating concept for someone who's just struggling to try to learn how to give a test. Is that what they're arguing here is that most of these tests aren't that great because they're not really capturing language, and most of the tasks they do are kind of experimental. And even then, at our best shot, our diagnoses are often incomplete and ambiguous. We don't fully know the disorder. This might be taking it a little too far, but I think having this framework in our mind that these tests are giving us good information, but they are inherently flawed. And I know what these flaws are. We're going to talk about these flaws throughout the semester. And I want to be skeptical of the test. I'm going to take the information, I'm going to interpret it, but I always want to have a healthy level of skepticism in my mind. I need to, I can't just be wishy-washy my whole life. Now, I do need to make diagnostic decisions, but at the same time, I want to constantly be evaluating and problem solving and saying, did I get this right? And being flexible and saying, initially I thought this was disorder A, but I think this might be disorder A and disorder B. So for example, initially I thought this was just a phonological disorder. But now that I'm getting to know this child more, and see that it's much more than just the speech, it's also the language. He's having difficulty with his receptive and expressive language skills. That's the type of clinician we should be. I always tell the story in this class. I gave the example before of the SLP who was, who said, I know this is accurate because I've been doing it for the past 25 years, very confident, maybe it's 20 years, very confident, very sure of herself. And when I think of, I've met lots of SLPs, I worked with lots of SLPs. When I have one of the best SLPs in my mind, I remember, she just inspired me and it was really phenomenal at capturing, what the kids' issues were and really identifying great treatments. And you know, I remember one day she turned to me, she said, you know, after 25 years, I don't feel like I know what I'm doing. And I thought, that is the attitude that you want. It's not that she wasn't aware of tests. It's not that she didn't know what she's doing. It's just that communication disorders are really complex. These aren't easy. It's not easy to, you know, these don't follow a standard playbook. You know, we need to constantly be questioning ourselves about what our decision making is, and that is the super SLP. So as we're trying to become the super SLPs in training, we want to think about this. You need to establish a certain baseline skill set of administering tests and interpreting the tests, and we're going to cover that in this class. But I want you to go on in your careers not just blindly interpreting standardized tests and not just giving the easy diagnoses and relying on these heuristics. I want you to constantly be questioning yourself. You know, that's what in my mind the really good SLP is. So, you know, as being the super SLP, I think her name was Anne. I think that was what really intrigued me with her, was she did have this persistent curiosity. She was always trying to figure the kid out. And not trying to figure the kid out by giving them 25 different tests. Trying to figure the kid out by, I gave you a test, I've identified a disorder, but in this treatment program and in these early sessions, I really need to figure out what's going on. What are your strengths? What are your weaknesses? What support system do we have? What treatment is going to be most effective given your individual profile? So really, you know, this is a problem, and we're going to use problem solving to get through it. We're going to try some things. If they don't work out, we're not just going to keep doing them because that's what we're doing. We're going to revise our plan. Okay. We also want to think about, when do we do our evaluations. The one type of evaluation we don't really do these a lot, is universal screening. So some examples of this are, newborn universal hearing screenings. Some school districts may have SLPs help screen every kindergartner for speech language communication pre-literacy skills. You may do screenings for people for cognitive function. But, so with these, you're going to have a relatively low hit rate of people with pathologies, and we tend to want to overestimate the people that we think might have a pathology so that we can then do a more comprehensive assessment. The majority of our work is in diagnostic referrals, so the majority of our assessments come to us from people who think that they have a problem or think that their child or family member has a problem. One set of assessments, the most common is like the comprehensive diagnostic evaluation. I'm going to call this the high stakes assessment. That's more of an educational term, but I like it. Because what you're really doing is very high stakes. You're doing a single assessment, and it's high stakes. You either have a disorder or you don't have a disorder. And it's what we most commonly do. Some of you brought up the limitations of this approach last time. What if the kid's having a bad day? What if you didn't know how to take the test? What if you were testing things that weren't really that important? What if you're testing things that he was good at, but you missed things that he was really struggling with? But on the flip side, we have a lot of assessment tools in these high stakes assessments that are pretty good. I mean, they are pretty good at what they do. Much better than just flipping a coin. So we have to weigh that in. We're also going to talk about two other types of these. I put these more within the diagnostic referral. And this is going to be more like one of our last lectures. We're going to talk about, what do we do when we get a kid and we're not sure, and we're going to start an assessment and see, do they respond to that assessment or do they not respond to that assessment? Or treatment, I should say, I'm sorry. So we're going to put them in a treatment. We want to see, do you respond to that treatment or do you not respond to the treatment? So we're really going to talk about the theory and the logic with that down the road. But there are other ways to make these high-stakes decisions or these diagnostic decisions that don't involve a one-stop shop. The problem with this is a lot of our institutions don't conform to this. So, if you're working in a hospital, you often don't have the luxury of saying, well, let's wait for a month and then I'll tell you whether or not he has a disorder. In a school, we're getting more towards this, response intervention model, but still, especially in Wisconsin, for speech language services, it's still the high stakes model where you have to determine there is a disorder or there isn't a disorder. If there is, you get assessment. If there's not, you don't get assessment. And then we also use our evaluations and progress monitoring. So we can use these, this is what you all do, collecting data during your assessments. And what you should really be using that data for is a formative assessment. I like this word, formative assessment, because it helps us form our impression of the client and helps us form our future plan. That's the formative part of it. So if our client is going nuts and doing great in our intervention, maybe we want to keep it up or we want to move on to the next objective, raise the stakes, keep pushing the client and get them higher and higher. On the flip side, if our client isn't making any progress, maybe we don't want to beat ourselves against our heads against the wall anymore. Maybe we want to start introducing a new intervention to see if we can start getting that growth and that progress. And then finally, we do need to remember that our impairments, while we know that they have, most of our pathologies have the prognosis of long-term disability, they're not, all of our diagnoses aren't sentencing people to 3 years to life of speech therapy or of speech disorders. So, we do need to make discharge decisions and have accurate data to be able to do that. So that's the Blitz. Again, I'll answer any questions you have about this on Wednesday. And all of these concepts are going to come up again throughout the semester. But I think they are really important concepts, so I wanted to get them through to you. So again, I apologize for today, and I hope you all have a great couple of days, and I'll see you on Wednesday.